Good morning, everyone. It is my great pleasure to introduce a well-known friend to Australia and RANZCO, Professor Donald Tan. He is a senior partner at the Eye and Cornea Division of Eye and Retina Surgeons and clinical professor at the Ophthalmology and Visual Sciences Academic Clinical Program at Duke National University of Singapore. A founding doctor and previous medical director of the Singapore National Eye Centre, Prof Tan is a global leader in the field of cornea and refractive surgery, with major contributions to the development of new techniques and devices in these fields. He has published over 430 peer-reviewed articles and is the recipient of over 30 international awards. He has taught generations of ophthalmologists, and I myself was lucky enough to train as his corneal fellow in Singapore. With humour and finesse, he taught me the complexities of lamellar corneal transplantation surgery. Prof Tan was a past president of the US Cornea Society and founded the Asia Cornea Society and the Association of Eye Banks in Asia. He is immediate past president and Secretary General of the Asia Cornea Society. He is a man of many talents, including distilling whiskey with local Singaporean flavours and playing the cello. We look forward to Prof Tan's lecture, the Cornea Update Lecture, DMEK, the Artificial Iris, and the Virtual Corneal Clinic. Welcome, Prof Tan.
Thank you, Andrea. It's great to be back in Australia after COVID, and I really want to thank RANZCO for inviting me. This is one of my first meetings for about 3 years, so it's great. We seem to have gone backwards. Do we go forwards? Okay, so anyway, that was my title slide. It's important to note that I have a vested interest in the EndoGlide device that we use for corneal transplantation here. It was an vested interest. So when we look at the long-term review of penetrating keratoplasty, this is a paper we published fairly recently, a 20-year review. All the curves look pretty dismal. At this point, I always want to remind everybody that the best corneal transplant registry today is still right here in Australia, the Australian Corneal Graft Registry. But if you look at our graft survival rates, do I use this? Yeah, oh, that one, okay. So I'll just use this instead. So if you look at the survival rates, first year looks great, gets fairly dismal by the time you hit 20 years to 44%. If we look at Fuchs endothelial corneal dystrophy, which is the Western form of endothelial dysfunction and bullous keratopathy, if we just look at 5-year survival rates, you then see very quickly that there is a big difference between penetrating keratoplasty, Descemet's stripping, automated endothelial keratoplasty, and Descemet's membrane endothelial keratoplasty, or DMEK. And you have a look and see that at 5 years, about half our PKs have failed. DSEK, we still have 78% surviving, and DMEK, 97%. Now, if you break this down, and we compare the two different diseases, and they're very, very different. If you look at Fuchs endothelial dystrophy, you will see that actually PK is not so bad, it's 73% graft survival, but DSEK and DMEK are very good, 96, 98%. So really doesn't matter whether you do a DSEK or a DMEK. But in many parts of Asia, especially in Singapore and other countries in the region, it's a different story. Our main corneal dystrophy, endothelial dysfunction is bullous or pseudophakic bullous keratopathy. And here, there is a significant difference. Now, I've just gone backwards. But here, if you look at the graft survival rate, PK is now 47%. DSEK is not that good, 65%, but DMEK is still pretty good. So there is a clear stratification. And that's the reason why we should perhaps be looking at DMEK a little bit more. When we started to do DMEK, I tried to follow the what we did for DSEK. And this is the endoglide that we devised. And the problem with DMEK, of course, is pure Descemet's membrane. And so we thought, let's put the stroma back. And this was a stromal substitute. This was a contact lens that we used. And that was a lot of regulatory hurdles. And then we thought, why don't we just use the stroma back again? So we developed a hybrid DMEK technique in which we pulled the Descemet's membrane on the stroma, but we had pre-detached the stroma, and so we just pulled the Descemet's membrane in. And then finally, the later version was we developed a smaller device, the DMEK endoglide, that was about 3 or 4 years ago now, in which we just put Descemet's membrane in through a smaller incision, which provided a lot more control of the anterior chamber. And that became our standard. Now, the problem, of course, is not all cases of endothelial dysfunction are created equal. This is a beautiful live surgical slide from my colleague Rajesh Fogler in India, where he's doing a perfect DMEK, where he's tapping very gently and everything's working well. View is pretty good. Chamber looks good. No peripheral anterior synechia. And when we do this, after we learn the tap dance of DMEK, then we feel very confident. And we can do this very well most of the time. However, this is quite often what we end up with, and it's a different situation, isn't it? Here, there's poor visualization, there's peripheral anterior synechia, so now your chamber is all conflicted. There's a dilated pupil, abnormal chamber, that IOL does not look in the right position. There could be an open posterior capsule vitreous or an unstable IOL. So I think it's going to be very difficult to try and do what you're doing on the left on the right. And people have published that these are all relative contraindications, aphakia, blebs or valves, ACIOLs, but this is the real world situation that we have in many parts of the world where we have to do a corneal transplant. So these are the most challenging cases. These are all cases of corneal decompensation with anterior segment disorganization. What are some of the characteristics? The anterior chambers are limited by peripheral anterior synechia. Of course, these are iris adhesions. There may be IOLs in the chamber. Certainly, there will be tubes as well. And very importantly, the posterior aspect, the posterior surface of the AC. Now, when we do DMEK, we have to tap on a normal iris. There is no normal iris here. They could be a dilated pupil, an open vitreous cavity, or even aphakia. And of course, you can have ACIOLs there. And even if you can do DMEK in these cases, we see that the peripheral anterior synechia recurs easily after a few weeks to months. That leads to graft rejection and failure. So here's one of my cases. This is a 61-year-old man who had glaucoma, and he came with a failed PK. He had a complicated phaco with glaucoma. He had a mitomycin C trap, a Barvell tube, 360 PAS, because after the PK was done, this happened, and of course it failed. And I managed to do a DMEK in 2017 with complete synechial. So we opened everything up. You can see it's a nice deep chamber here, and vision was 612. But it didn't last. Angle started to zip up again, pressure went up, TCP was done. That led to another tube in place, a second Ahmed valve this time, and then the PS recurred. And so, of course, my DMEK graft failed. He went back to count fingers vision. So the recurrence of PS in these complex cases is common and jeopardizes long-term success of your DMEK graft. So, what I've shown you before, these were the two concepts we had previously derived. The pull-through technique, where we're actually holding on to the DMEK tissue, provides you more surgical control of the donor. And then with a closed chamber system, you get better control of the AC depth. So we then decided to try and improve the situation with a third surgical principle, and that is to control the anatomy of the anterior chamber now. So if we can restore the anatomy of the AC, remove the PS permanently, remove the abnormal iris, and then replace it with a more controllable artificial iris, perhaps we can do better. So the technique here is, the concept is to restore or reconstruct the anterior chamber. This is the Human Optics Custom Flex artificial iris from Germany. It is an FDA-approved device. It's been FDA-approved for about, I think, coming to 4 years now. And what we're doing is to restore the posterior surface of the AC. We restore the iris and the pupil. We do that by removing the abnormal iris and replacing it with an artificial iris. That removes the risk of recurrence of PAS, which then, in theory, should lengthen the lifespan of the DMEK graft. So here's a patient, a complex pseudophakic bullous keratopathy, underwent a complicated phaco in 2019. There was a PCR, dropped nucleus, and dropped IOL. During the pars plana vitrectomy, there was a choroidal hemorrhage, and the procedure was abandoned. And then a month later, they went back in again, retrieved the IOL, and sclerofixed this IOL. Vision wasn't bad initially, but then fell as the cornea decompensated, and there was glare from a fixed pupil with 270 degrees of PAS. So the concept here was to stage the surgery. We would want to normalize the chamber first, remove the PS, restore iris morphology, stabilize the IOL, etc. And then after that, we would go in and do a DMEK. So here's the first stage. And it's quite a long procedure, but basically it took time. We had 4 peritomies, and you can see that we pre-marked the incisions. These are where the sutures for the artificial iris would go, 1.5 millimeters behind the limbus. This is an MVR blade. So we created 8 holes basically for the sutures. The current technique for a artificial iris is just 2-point fixation, but because we're doing DMEK, we decided to have 4-point. And here I'm using a marginal dissector, the ones we usually use for DALC, and that's a great separator for PAS. And in some cases, we've removed the iris with a vitrector, or we've just left it in place. This is the artificial iris, which is trephined 1 millimeter less than the white-to-white, with 4 pre-placed Gore-Tex mattress sutures. And inserting this through a scleral incision is about 4.5 to 5 millimeters. And one has to be quite careful here, because when we are flipping this artificial iris in place, we have to be careful not to dislocate the IOL, which could be gently, usually very gently, sclerofixated. And this, what we're doing is we're trying to create a normal anterior chamber. These sutures are then exteriorized, tied off, and the knots are rotated. And that's the end of the first stage. This is what it looks like after the first stage, and you'll see that initially there's some fibrin and some hemorrhage. So DMEK at this stage would have been very difficult, but it does settle down. And a month later, this is completely different situation now. The eye is much quieter, there's no PAS, and now this becomes almost like a standard DMEK procedure. The advantage of the artificial iris is you can't get an iris prolapse, the chamber stays in place. And here we're using the DMEK endoglide, where we pull the donor through. In a trifold, endothelium is facing inwards. And this goes now through a 2.7 millimeter clear corneal incision. It's important to place the artificial iris at a slightly shallow level so that you do achieve a shallow chamber. There is an artificial chamber maintainer opposite at the nasal area, so we're going to pull the DMEK graft into the flow of the anterior chamber maintainer. And everything is very slow, so the amount of fluid entering is really, really very slow. And now you can see that we're able to transform this case into a pretty standard looking DMEK. This is what it looks like, 7.5 at 2 weeks. Pretty reasonable cell count at a year, 1,800 cells. And that's the other eye for comparison. Here's that second case I showed you initially, where I did a DMEK and that failed. We did exactly the same procedure. This is after stage 1, where now the AC is well reconstructed with the artificial iris in place, no more PAS. And then again, it's a very similar procedure. Of course, this is a little bit more challenging because there's a PK, your visualization is not quite as good, but essentially it's also a fairly normal looking DMEK procedure now. And you can see this patient had a good outcome. And we're not worried about PAS. So in the post-operative follow-up period, we think it's going to be a much less stormy period. Just skip that. And this patient gets about 6/12 vision. So these are some of the cases before surgery and what they look like after surgery. And we published this a couple of years ago in the British Journal of Ophthalmology. Since then now, the current series we've probably done, this is what they look like after the first and second stage. About 11 cases of high-risk corneal decompensations. On average, 9 out of 11 had pre-existing glaucoma. Of these, 7 out of these 9 cases had mostly tubes in place. 7 out of the 11 had a total of 17 failed grafts. So these were all repeat grafts, a lot of them. The average had about 2.5 grafts per eye before surgery. And at a mean follow-up of about 20 months, all cases have been successful. 9 had DMEK, let's go back. 9 had DMEK as their second stage surgery. Because of COVID, the lockdown, we had to do PKs on 2 of these eyes instead of a DMEK. We've had 1 DMEK failure where there was persistent edema, and that's probably due to hypotony and the eye went thusical. We had 1 case of retinal detachment in which the patient did not elect to have further surgery. So these are really complex cases, and I think the surgery is just half of the problem. The other half is what's going to happen after the surgery. And so, as all corneal surgeons know, follow-up is so important. During COVID, we had a big problem because we couldn't see our patients, and especially patients who flew into Singapore. Keratoplasty patients, especially those complex cases I've showed you, require constant follow-up. They're always on the cusp of either rejecting or having glaucoma or having rejection. They're on steroids, glaucoma medications, etc., etc. And so prior to COVID-19, many patients from Southeast Asia came to Singapore for their regular surgery and follow-up, and that was fine. But in March 2020, the government in Singapore imposed significant travel restrictions on foreign medical patients into Singapore, and of course, like everywhere else here and in Singapore, we had lockdowns as well. And so in March 2020, we established a program between my clinic, the eye and retina surgeons, and the Jakarta Eye Center. A lot of my patients were from Indonesia, and we developed a new telemedicine initiative, initially specifically geared to look after these patients and these complex cases. I want to tribute to the medical director, Dr. Johan Hutaruk, and Dr. Sharita Sirigar for helping to establish this program, which we call the Virtual Corneal Clinic. So here we are, I'm in Singapore, my patients are in Indonesia, and they can't come and see me for follow-up. Either the patients called us and said, how do we see you? Or we contacted all these patients and told them there is an alternative approach. We counseled all of them regarding the possibility of a telemedicine virtual corneal clinic, lots of informed patient consent. I think we all understand the challenges of getting consent for telemedicine and the implications of trying to determine treatment from afar. Once we got the full consent, then we would send email medical summaries and clinic appointments to the Jakarta Eye Center, which would then contact the patient. So these are some of the emails. This is an email that we sent to the Jakarta Eye Center saying this patient needs what needs to be done. Very brief summary. So literally, these were what it is. So this is one of my patients: bilateral primary angle closure glaucoma, left pseudophakic bullous keratopathy, left DMEK in 2017. Last seen. This is the vision. There's a bit of cataract. What's the pressure and what's the medication? That's the informed consent form. Once that was signed, then the Jakarta Eye Clinic would then call us, or they would give us an email and say, this appointment has been booked, including a Zoom login time. So the patients would come to Jakarta Eye Center. They would maybe come about 2 hours before, because there would be a pre-examination test. So we'd already specified, please do the specular imaging, or let's do the anterior segment OCT, etc. beforehand. And then we would have a virtual corneal clinic. We would review the medical summary. I would talk to the corneal doctors there. We would do a real-time video slit lamp exam, do a discussion, and then make decisions. So corneal specialists in Singapore, corneal specialists in Jakarta, but at the same time, in the next door in my clinic, I had a glaucoma colleague, they had glaucoma colleagues, so we had retina colleagues, oculoplastic colleagues, all coming in on that virtual clinic. Not only that, sometimes we often had patient relatives as well participating in that Zoom. So this is the video at the Jakarta
Sekarang keluhannya gimana, Pak?
Clinic.
Jadi keluhannya kadang-kadang mata terasa lebih nyaman, terus agak terang gitu. Oke. Terus saya tetes mata pakai. Jadi sekitaran.
That's a patient who had DMEK with the arterial iris. He's looking at a screen.
Hey,
I'm looking at a screen.
Fine.
Mr. Janto, ada baik?
The medication is out of stock. Garford and dialysis. Sama Azov.
After the DMEK, I think his operation was done in March. So he's now exactly 7 months artificial iris implanted in the capsular bag. Significant glaucoma, if you remember. So he's still on Azov. Left eye is Simbrinza twice a day, right? On Predmire 3 times a day?
Yes.
Okay, good.
This one is today. Can you see
Yes,
it?
I can.
Over 60. The left eye is 660. And the pressure
Okay.
of the right eye is 12. The left eye, maybe we will check with
I think the pressure has always been quite low.
This is the OCT of the left eye.
Okay, macula looks okay.
The OCT of the right eye.
Atrial.
Yeah.
Yeah.
This is the count. The right eye 2600.
Okay, that's 480 microns, which is also very good. So this is the eye with the DMEK and the artificial iris.
The anterior chamber
Yeah.
is also this.
The graph looks very good.
This is the left eye.
Very good. Okay, he's doing fine. By the way, I think he was quite a cup disc, right? Was there a pin is 660?
Let me check. CT optical head. This is the KMN.
So it's quite important to maintain a low intraocular pressure. Bagus.
So the patient vision little bit blurry.
That's
Only
okay.
Terima ya.
3 bulan datang.
Januari.
Okay.
Ketemu? Ya. 3 bulan lagi.
Okay, bye, Mr. Tora.
It wasn't as frantic as it sounds. We sped up the video a little bit. So, did we make a difference? So, over a period of June 2020 to April 2021, just about a year, there were a total of 72 post-keratoplasty cases. In fact, they were not all my cases. There were 12% new cases as well. So once we realized this is a great avenue, we had patients coming to Jakarta who wanted to have a consult with me. We had 3 corneal surgeons I was privileged to work with, and so we would run clinics. We would go into one of their clinics, I would be in my clinic, we would book a time slot. So I would be running a normal clinic in Singapore, I would book a 20-minute time slot for a virtual corneal clinic for this patient. We had glaucoma surgeons, retina, oculoplastic, and pediatric as well, on both sides of Singapore and Indonesia coming in. Overall, if you look at the transplant patients, 42% were DMEKs, 16% DSEKs, 12% PKs, DALKs, and we even had some K-Pros as well. So did we make a difference? Well, we managed to get urgent approval to fly in 5% to Singapore for urgent surgery. The Indonesian corneal specialists also intervened surgically 5% of the time following our virtual corneal clinics. Importantly, we were able to refer these patients to other subspecialists, to glaucoma colleagues, oculoplastic and pediatric colleagues in about 16%. And about 80% were actually had their medications changed. So only about 20% were just like business as usual, you're fine, carry on. So we made a huge difference in altering the medical treatment and surgical treatment of these patients. So no change, only in 20%. So in summary then, DMEK appears to have major advantages in terms of visual performance and reduced risk of allograft rejection, but comes with significant surgical and technical challenges, especially in eyes with extreme complex cases of anterior segment comorbidities. The pull-through endoin approach to DMEK provides for better surgical control of the donor, whilst restoring the anatomy of the anterior chamber with the use of the artificial iris enables DMEK to be performed in the most challenging cases of endothelial dysfunction. What's important, of course, is regular and lifelong follow-up of keratoplasty patients, as we want to prolong graft survival in all these patients. And the concept of a virtual corneal clinic, I think, is a new approach in this post-COVID era, which we can not only use for our follow-up patients, but also to enhance physician interaction between our subspecialists and, in fact, outside of ophthalmology as well. And this can hopefully enhance our efforts to keep our patients healthy and seeing well. Thank you very much for your attention.
Prof. Tan, thank you so much for your amazing talk and the amazing surgical skills doing those complex anterior segment cases. I think we have time for 1 or 2 questions. If anyone has a question, please come forward. Otherwise, I was going to ask you, Prof. Tan, so now that you've developed this clinic and the systems around it, do you think you'll continue using this, even though we can fly now?
Yeah, I mean, you know, nothing's still is as good as a face-to-face examination. I mean, I am having to rely on my corneal colleagues, and it's quite interesting, you know, for example, in a DMEK or a PK for that matter, you're looking for fine KPs, right? And I can't see that on the screen, but I can direct my colleague to say, can you just look around, you know, is that a KP, et cetera? But it's not as good as you doing it yourself. All right, so that's what we tell patients. I think for some patients who can no longer afford to travel or they're too ill, this virtual cornea clinic is just great. All right, it's very good for an initial referral where a physician wants to ask me, is there anything I can do for this patient? We've done that now. So some patients, we do a virtual cornea clinic, and I said, well, looking at this, I think your visual prognosis is really bad. Don't come to Singapore, you know. But I don't think it will replace a real-time examination.
Thanks so much. There's one question at the front.
Prof, thanks very much, and that was excellent. Just in terms of your artificial iris, you'd say you remove the iris that's already there, or you just put it in front of the iris untouched, so to speak? And I heard on the video there, obviously one of the artificial irises went within the bag. I presume that can be in the bag and the sulcus or in front of the iris. Just what do you actually do in terms of the existing iris, I suppose?
Sure. So this artificial iris, there are two versions, one which you suture, which you can suture, which has got more of a fibrous texture, and one which you don't. The one which you don't suture is usually in the bag. And that's the one which in the US most of the cataract surgeons will use, and that's the one you put in the bag. So that patient you saw there had one in the bag, yet he was almost totally aniridic. And we put a CTR, we did the phaco, did the CTR, and put the artificial iris in the capsular bag. All the other cases are the ones with big peripheral anterior segment comorbidities, you know, and quite often there's no more bag anyway. All right, so they're all sutured in place. The challenge, of course, with these suturings is to get it at the right plane. Did I answer all your questions? Yeah. But most of them were outside the bag, the kind of sclerofixations, and we use the Gore-Tex suture for that.
Thank you so much, Prof, for your talk and your time and coming to Australia.